So today we're going to be talking about acyanotic congenital heart disease. We'll discuss kind of the anatomy, some of the pathophysiology, and then try to characterize them and what we look for on echo, both transthoracic and TEE. And so we'll specifically be reviewing atrial septal defects, ventricular septal defects, as well as patent ductus arteriosus. So to start with atrial septal defects, essentially all of these will be an abnormal tissue communication between the right and the left atria. There's 4 specific subtypes, probably most familiar with secundum defects as well as primum defects. And then the more rare variants of these defects are sinus venosus and coronary sinus ASDs. So unfortunately, we can't really do any talk about ASDs without doing embryology first. And essentially, I'm going to try to simplify it that there's really 3 key structures that you have to know. The first thing that forms in early embryology is the septum primum. And this is essentially a septum that comes from the atrial roof down and starts to form the beginning of the septum. After this, the septum secundum forms, and that's essentially just a muscular ridge on the right atrial side of the septum that then forms basically a ridge that then creates 2 separate septums, and they kind of overlap over time. And so failure of these overlapping structures to fuse essentially creates a PFO, which we're very familiar with. But if there's defects in any of how these septums form, like a tissue defect, that's going to form an atrial septal defect. And the spectrum of pathology is quite wide. When you think about tissue defects, they can be fenestrated, they can be partial, they can be complete. And so that's why we can get ASDs essentially anywhere on this continuum, or multiple ASDs at once. Typically, a PFO fuses about 2 months after you're born. And that's because just the difference between the left and right atrial pressure eventually squishes the 2 kind of sheets together, and that causes fusion. So when we think of the clinical features of ASDs, I like to go back to the pathophysiology. So because there is a defect in the interatrial septum, essentially due to chronic left to right shunting, you're going to get enlargement of your right-sided chambers. So over time, you get progressive right atrial distension and remodeling. This can lead to arrhythmia because of stretching of the circuits around the right atrium. And then you can also get progressive right ventricular distension. And so this is going to cause annular dilatation, functional TR, and eventually this might cause symptoms of right heart failure. We're on to something here with Rheaume in the room, which is good. Symptoms, and then outside of right chamber dilatation, because of the enhanced right ventricular flow, you're going to get excessive pulmonary vascular flow. And over time, this leads to pulmonary artery remodeling, which eventually can form a type of pulmonary hypertension, type 1 in particular. Symptoms of ASD are not very specific early on. Usually patients just have exercise intolerance. And then slowly over time, as they get these progressive remodeling from the right atrium or right ventricle, you'll get arrhythmia, right-sided congestive heart failure symptoms. In addition, due to the presence of the shunt, you can get paradoxical emboli. Physical exam features that come up with atrial septal defects. You can get a left parasternal heave due to RV dilatation. As opposed to your physiological splitting of your heart sounds, you'll be left with a wide, fixed splitting due to enhanced right-sided flow. You can get a pulmonary ejection murmur due to enhanced flow across the pulmonary valve. Tricuspid regurgitation due to annular dilatation. And then interestingly enough, you can also get a diastolic flow throughout the tricuspid valve just due to enhanced flow on the right side. ECG abnormalities that are common with ASDs depend on the type of the ASD. So primum ASDs predominantly involve the interventricular septum and the endocardial cushions. And so because you have a defect in the septum where the conduction pathway moves through, you're going to have more pronounced defects. So typically they have a complete right bundle and a left axis deviation, whereas secundum defects, just because they're in the where fossa ovalis or PFO is, you typically just get an incomplete right bundle branch block. Mike Ruiz to the rescue, as always. Common theme in our first month of Echo Fellowship. Okay, he's just logging in on the system here. Do you mind just logging into Zoom and then put it in there? Okay, perfect. So in terms of TE evaluation for intraatrial defects, one of the keys is really just imaging in multiple echocardiographic planes. So the intraatrial septum, as most of our sonographers will tell us, is actually very difficult to image. There's lots of dropout. It's more of a distal structure in a lot of our views. And so really you have to interrogate the septum over various planes. Because a lot of the indications for intervention are the symptoms that patients experience or the remodeling changes that happens in the heart, it's really important to look for complications of ASD, because that's often the first clue that can then trigger you to look at the intraatrial septum a little bit more carefully. And so isolated dilation of right-sided structures in someone who's young and has no other real reason for chamber dilation really should prompt you to interrogate the intraatrial septum a little bit more carefully, both with color as well as agitated saline. As much as possible, we try to estimate the pulmonary pressures, because that's going to be very important in terms of gauging severity of the ASD as well as tracking progression over time. So if we're able to get an RVSP from a TR jet, otherwise looking at indirect findings of pulmonary hypertension, such as PA dilatation. Next, about estimating pulmonary pressures, and then probably most important, because this is going to have significant impact for if you're going to be able to intervene on these patients, is you want to look for other congenital abnormalities, because really with congenital heart disease, it's very common to have other congenital abnormalities, multiple ASDs, anomalous pulmonary veins. And so it's important to evaluate for all of these structures, that it's going to end up dictating some of your management. So specific things we're looking on transthoracic is, again, physiological consequences of a left to right shunt. So we're looking for chamber dilatation. We're looking for septal flattening. Ultimately, you initially start with volume overload, which then translates to pressure overload and septal flattening in both systole and diastole, as your pulmonary pressure continues to increase. Look for signs of TR, IV dilatation, and then enhanced pulmonary flow. So you may see high velocities on PW when you look at the pulmonary veins. As mentioned, the intraatrial septum is difficult to visualize. Subcostal is typically the best. Color Doppler and agitated saline are very key for looking at this. And in terms of associated abnormalities that you can look for, atrial septal aneurysms do fall in line with PFOs and ASDs. And so you're looking for that tissue being quite redundant and mobile, and our typical cutoffs are about 10 millimeters of excursion on one side or the other. It is possible to look at the QPQS, which can be a bit of a scary formula for trainees, but really, to simplify it, is just looking at the total blood flow leaving the pulmonary system and the systemic circulation. So if you break it down, you're really just looking at the stroke volume leaving the pulmonary circulation and the stroke volume leaving the systemic circulation. Probably one of the harder dimensions to capture with this is getting a proper RVOT, as that area can be difficult to image. So similar to your LVOT diameter, you're going to need an RVOT diameter. So that's sometimes the challenge in specifically quantifying this. Typically for these types of defects, we can also get a QPQS through hemodynamics and using the Fick equation for pulmonary and systemic flow. And so agitated saline is really, really critical in terms of identifying these shunts. So saline contrasts with prolongative maneuvers up to 3 or 4, either that be intra-abdominal pressure, tilt table testing, or asking the patient to do Valsalva increases the sensitivity up to almost 95%, where color Doppler kind of leaves you in the 25% area, especially for smaller defects. And so due to pressure gradients, most shunts are predominantly left to right. But with provocative maneuvers, we can reverse the shunt and see contrastive bubbles, are usually a puff of smoke and small defects from right to left. With very significant left to right shunting, we see a phenomenon called negative contrast, which I'll show you on the next slide. And there's a couple of tricks in terms of where you inject the contrast that can enhance your ability to detect a PFO or a small defect. So lower extremity contrast, so putting an IV in the foot and ingesting contrast can actually increase your ability to detect a PFO that's lower on in the septum. If there's a prominent eustachian valve or Chiari network, it may not direct blood flow very well from a typical upper extremity contrast. So using a lower extremity, you can have the microbubbles kind of interact with the atrial septum a little bit better to unmask more occult PFOs. And so this is an example of negative contrast. You can see there's a significant left to right shunt, and instead of bubbles actually crossing the septum, you see this phenomenon of negative contrast where there is essentially, you can see the shunting blowing kind of a hole in the contrast that we're seeing. So when we specifically talk about the types of ASDs, the most common is an ASD secundum. And again, this is a deficiency in the septum primum tissue, so the initial tissue that forms from the atrial roof. Again, the spectrum of pathology can be quite wide, either partial, total, or fenestrated. ASD primums are the second most common. This is due to inadequate fusion of the septum with the endocardial cushion just above the AV valves. And so typically these lead to a variety of other pathologies. You get atrioventricular defects, so not only a defect in the interatrial septum, but also they can be associated with an inlet VSD just below the endocardial cushion. And because of its intimate association with the AV valves, typically you get congenital abnormalities with the mitral and tricuspid valve. And so this is example of a very prominent secundum ASD. So again, initially you should train your eye to look that the the right ventricle is very dilated, both in the long axis as well as short axis. We almost never see this unless it's a truly large ASD, but in the short axis, as well as the apical 4, we can see color flow across the septum. And then the apical 4 chamber, we can also see color flow. Now, as mentioned before, a lot of these views are usually complicated by dropout. So you can see what's like a superficial defect here. We don't often see the color flow in these views, much more common in the subcostal area. And then for primum ASDs, you can see that the defect is essentially right at the level of the AV valves. You can also see equalization of the AV valves, both the right and left, where they're on the same plane, where usually there's some apical tension of the tricuspid valve. And these are typically associated with, again, a variety of valve lesions. So there's significant TR here, as well as primum ASD. Sinus venosus defects are something that is a little bit more difficult to get your head around. So they're not true defects in the interatrial septal wall. They're almost always associated with anomalous pulmonary venous connections, because the defect is actually between the SVC or the IVC as well as a pulmonary vein. And so it's much, much more common to get an SVC type as opposed to an IVC type sinus venosus defect. And so there's actually more of an unroofing of an anomalous pulmonary vein, where there's a connection between the pulmonary vein as well as the SVC, and that's leading to the left to right shunting. One of the tips here, again, is lower extremity contrast can reveal an occult IVC type sinus venosus defect, just because your defect is going to be towards the bottom of the screen there with an anomalous pulmonary vein unroofing just behind the IVC. And so if you inject contrast just coming from the SVC, you can see how you may miss the defect because the microbubbles are just going to go from the IVC down into the right ventricle as opposed to targeting that interface between the IVC and the lower pulmonary vein. And so very infrequently, we can see these on transthoracic. It's very difficult to image because we typically don't see the SVC in transthoracic, but in the modified subcostal view, it is possible to see the SVC, and we can see a communication defect here, as well as in the modified short axis in the subcostal view. Most of the time, what's seen in these patients is that we have right-sided chamber dilation that's not explained by any other pathology. And then typically these patients have a very positive bubble study that then allows us to interrogate it more carefully with TEE. And so we can see on TEE, the defect is much more obvious as we interrogate the interatrial septum. And we'll get to a case later about this. Coronary sinus pathology, again, is not a true defect in the atrial septum. And so it's actually a communication between the roof of the coronary sinus and the left atrium. These are almost always associated with persistent left-sided SVC. So as opposed to your SVC crossing over and coming into a common SVC here, we see a direct communication that's draining into the coronary sinus. And then this results in essentially a shunt between the venous return as well as the systemic circulation. If this is very large, it can lead to cyanosis just because you don't get oxygenated blood coming through. But typically there's kind of mixing between the right atrium, the left atrium, because of this sinus defect. The most common thing that we see in these patients is actually just a dilated coronary sinus that's not explained, which then allows us to interrogate for this. In terms of using agitated saline, one of the tricks is to inject in the left arm because that's going to directly inject into the anomalous persistent left SVC. And so before you get any opacification of agitated saline in the atrium, you actually get opacification of the coronary sinus, and then you see microbubbles crossing back and forth. And so again here, your eye is drawn to not only the RV dilatation, but you see a dilated structure here. The descending aorta is here. And so this is consistent with the coronary sinus, which is quite dilated. Typically, our thresholds are about 10 millimeters. And again, in short axis, we can see a very prominent coronary sinus here. And so TE is very important to not only for not only periprocedural planning, but to also identify if there's multiple defects and other associated congenital abnormalities that will become important to see if this can be fixed percutaneously or not. 3D assessment with TE is quite helpful as well. You can get full reconstruction of the ASD and the surrounding fossa. And the most important part for this is you want to evaluate for not only multiple defects, but the defect that you have of interest in making sure that there's appropriate kind of support of the surrounding tissue structure or rims to see if you can actually put an implanter device on this defect. And so this is a really good diagram and probably outside the scope of this talk, but you have your kind of three critical views where you're identifying your interatrial septum on TEE. And really, after these views, you want to just essentially angulate at 15-degree intervals to kind of scan the entire septum. And you're essentially looking for 6 specific rims to try to get full tissue characterization around the ASD to ensure there's appropriate support in all of these rims before deciding if an implanter can be placed. And so transcatheter closure is a treatment of choice for secundum ASDs because these are typically in the middle where a fossa ovalis or PFO will be. So there's typically adequate rims circumferentially. Whereas all of the other ASDs are typically not amenable to percutaneous closure just because of the nature of the defect. The sinus venosa and the coronary sinus, as mentioned, are not actually in the interatrial septum. They're an abnormality with the either anomalous pulmonary veins or coronary sinus themselves. And then ASD or primum ASDs typically are associated with the endocardial cushion defects, so they're much too low to provide any sort of percutaneous closure, and they usually have a variety of other valve associations as well, which makes surgical management more favorable. Okay, we'll move on quickly to VSDs before getting in some getting into some cases. So there's essentially 4 types of VSDs. Really, when you're scanning on transthoracic, again, because the ventricular septum is difficult to visualize just in 2D, you want to take all of your different views to try to characterize where the VSD is. And so there's 4 different types. There's your membranous VSD, inlet VSD, which is associated with AVSD, your muscular VSD, which is down in the muscle, and then the subarterial VSD can be a little bit confusing because there's really like 3 different names that are used interchangeably in the literature. But there's your subarterial, which is also sometimes called your outlet or your supracrystal VSD. Membranous VSD is going to be your most common, and this is near the membranous septum of the interventricular septum, just down here between the AV valves. Muscular VSD is going to be your second most common. This one's a little bit easier to visualize on TT because it's one of the VSDs that's away from the AV valves. And so it's typically lower down in the septum here. You can have multiple defects like Swiss cheese, or you can just have one isolated defect. Subarterial is up near your aortic and pulmonary valves as opposed to your AV valves. And then your inlet VSD is, again, just below your AV valve. And this is typically associated with atrioventricular septal defects, so your primum ASDs, as well as your valve disease. This is a good picture to take, which is essentially how we visualize our different VSDs on transthoracic. And so you'll see that because these all run in the same planes, the VSDs can appear similar on multiple views. And there's a couple of specific views that are quite important to distinguish between the different types of VSDs. So one of the views that becomes important is the aortic short axis view, because you'll see that a membranous VSD is more so near the tricuspid valve and will be at more of the 10, 11 o'clock area of the short axis of the aorta, whereas a outlet or subarterial will be past the tricuspid valve and typically involving the pulmonary artery more at the 1 to 2 o'clock range. The 5-chamber can be very important to further characterize membranous septum defects, because you can see in the 4-chamber or in the peristernal long axis, you can get like a variety of VSDs all kind of in the same plane. And so the 5-chamber actually really helps separate a membranous VSD. And so we classify these based on pathophysiology. So there's restrictive and unrestrictive. Basically, restrictive means that the hole is very small, so the degree of shunting is very low and the velocity is very high. So because the hole is so small, the pressure gradient is very, very high, and that will result in minimal amount of shunting, but high velocity between the two. So you'll hear a large holosystolic murmur. Because of high velocity shunting, you can get complications just from turbulent damage. For non-restrictive VSDs, because the pressure is almost similar, you sometimes cannot hear a murmur because there isn't that pressure gradient. There's not much velocity through that defect, and you can get equalization of pressures and development of pulmonary hypertension over time. With the high velocity jets, they can actually strike the RV outflow and valve endocardium, and this can damage the RV outflow. It can lead to hypertrophy and outflow tract obstructions, but also it can just lead to turbulent damage of the native pulmonary valve, which can be a nidus for bacteria and endocarditis. Specific to the subarterial and the membranous VSDs, just because these are so close to the sinus of Valsalva and the aortic valves, it can cause damage to the aortic valves as well as the sinus of Valsalva, which can lead to leaflet prolapse, significant aortic regurgitation, or defects in the sinus of Valsalva. I think we'll skip this part here and just go on to principles of TT evaluation. So it's, again, you're going to want to try to approximate what type of VSD it is and the size. The magnitude of shunting can be done due to when we look at surrogate measures, so chamber dilatation, but we can also do QPQS similar to ASDs. And as opposed to ASDs where you get right-sided volume overload, these VSDs, which are more chronic as opposed to our acute VSDs, which we see in MI, though these VSDs lead to essentially chronic left-sided volume overload. And so we have flow going from the left to the right side that essentially immediately enters the pulmonary circulation and overall leads to volume overload on the left side. So we start with left-sided chamber dilatation, which then leads to pulmonary hypertension, which then leads to right-sided chamber dilatation. One interesting thing is that we can actually calculate our RVSP by getting the velocity of the VSD as opposed to our TR jet. And we subtract our systolic blood pressure because that's going to essentially be your systolic blood pressure minus your left ventricular pressure, which will give you a right ventricular pressure. And so here is an example of how to do that. So if you have a VSD, which we're measuring the parasternal long axis, you can get the peak gradient through that and minus your systolic blood pressure. Importantly, this is in the absence of any LVOT obstruction or aortic stenosis, because that's going to compound your measurement. And you can actually estimate your right ventricular pressure through this formula. This is just color Doppler, which can help sometimes with the degree of shunting. So if you see shunting all throughout systole and diastole, if we pair it with M mode as well as our ECG, this is much more indicative of a restrictive VSD where the left-sided pressures are always going to be higher than the right-sided pressures, as opposed to an unrestrictive VSD where you may get some bidirectional flow because you get equalization of the left and right-sided pressures just due to the size of the defect. And so this is an example of a perimembranous VSD. We can see that in the parasternal long axis here, it's a little bit difficult to see what type of VSD because it's just at the superior aspect of the septum. But when we go over to the parasternal short axis, we can see that the color Doppler is originating from the 11 o'clock position as opposed to further down in the 1 to 2 o'clock position, which is more consistent with a perimembranous VSD. This is in contrast to a subarterial VSD where we see that the defect in the short axis is more at the 12 to kind of 1 to 2 o'clock past the tricuspid valve. Muscular defects are a little bit easier to identify just because they're much lower down the septum and they usually don't cross in a variety of different planes as opposed to the other ones near either the AV valves or the aortic and pulmonary valves. And then inlet VSDs, it's very rare to see an inlet VSD in isolation. Typically, you get an atrial septal defect as well as valve defects, but this is an isolated inlet VSD where we just see the septum is deficient here, but the interatrial septum is intact. Again, other clues similar to your primum ASDs is that you get equal leveling of the AV valve, so you don't see that apical tenting of the tricuspid valve. Okay. And quickly, we'll go through PDAs. We recently had one in the lab here, and essentially this is normal part of fetal circulation, which typically closes shortly after birth. The reason that it closes is because you get a drop in your intrathoracic pressures when the baby breathes. And so that leads to closing of the shunt as the aortic pressures are much higher than the pulmonary circulation. It behaves very similar to a VSD, so you essentially have left to right blood flow due to the high aortic pressures compared to the pulmonary artery pressures. And as opposed to right-sided chamber dilatation with ASDs, you get left-sided chamber dilatation. And essentially, that's because you're having passive flow from the into the pulmonary circulation, which is directly going to feed into the left side. Small shunts typically, again, have a very, very high gradient. They have high velocities, and they typically have a murmur throughout systole and diastole because of that persistent pressure gradient. Interestingly enough, as large shunts progress, the murmur actually decreases in intensity, and that's because your pressure gradient drops. So you get equalization of your aortic and your pulmonary pressures because of left ventricular remodeling, development of pulmonary hypertension. And so your murmur actually starts to disappear, as well as your findings start to disappear as the shunt becomes more progressive. You'll get other signs such as LV dilatation, displaced apical pulse, as well as loud P2, which are all essentially sequelae of adverse remodeling and development of pulmonary hypertension. Very, very similar to evaluation of VSDs. Again, you can get an RVSP from the difference in pressure gradient just using the systolic blood pressure. And so this is an example of isolated left-sided enlargement with a PDA. And you can see that in this view here on Doppler, you essentially have continuous flow, which peaks just after systole, because that's when your aortic pressure is going to be highest, and then kind of trailing off throughout systole into diastole, again, peaking with systole. And so this is like a classical like sawtooth Doppler pattern, where you get these peaking in valleys, but there's essentially continuous flow all throughout systole and diastole. There is the ductal view where you typically see PDAs, and essentially that's your aortic short axis, where you're going one rib space higher. And so that just allows better interrogation of the RVOT and start of the pulmonary artery, where you're going to be able to visualize this defect. Another view to see this is the suprasternal, where you will see an abnormal color flow. We don't have that much time left, so I'm just going to go to one case that's kind of prompted this presentation when I was training at McMaster. So this is just a simple ASD, which is kind of boring. But I wanted to demonstrate this type of defect. So we'll start with the transthoracic images. And you can see that there's coronary sinus dilatation here. You may get a hint that the RV may be a bit dilated, but we're going to look at that in other views. Fast forward here. RV is looking more dilated in this view. You get some septal shift. Moving down towards the apex, we see that as well. The RV is kind of similar size to the LV, indicating at least some degree of dilatation. Again, similar size. Right atrium looks dilated as well. And then when we're looking at our subcostal view, this is where we're seeing our interatrial septum, and we really don't see a lot of dropout there. There's no clear indication that there's a defect, but again, we have a dilated coronary sinus, as well as some dilated RV structures for no other kind of specific reason. If you looked at the full study, as we interrogate that more, still no defects. And then with color Doppler, don't see much hint of any kind of turbulent flow or shunting across the interatrial septum. And then we do our bubble study, and it's very, very positive. So essentially 4+ bubbles crossing pretty much immediately within one cardiac cycle. And so we don't see a true defect in the septum. And so this would raise suspicion for either a coronary sinus defect or a sinus venosus defect. And so this led to a TEE, where we can see that just where the SVC is here, there's a defect. And as we move along to a variety of colors, we see a separate type of flow coming in on the right side of the screen. And so as we scan across the septum, we actually see that this is one of the pulmonary arteries returning to the left atrium. And we can see there's unroofing in the connection between the two tubular structures, which is the SVC, essentially causing this type of shunt. And so you can see nicely both structures as you kind of fan across the interatrial septum here, where there's almost like kind of two pathways leading to the left atrium. And so this is most consistent with a sinus venosus defect and anomalous pulmonary venous connection with unroofing of the one of the pulmonary arteries. And so if I go a little bit further here, now this was a bit interesting. We actually did this by mistake. We were just doing a 4-chamber view. And we thought that the coronary sinus was dilated just because of the right atrial enlargement, but we injected on the left side first. And we saw that the coronary sinus actually opacified before anything else. We'll just replay that again. And so you can see that the coronary sinus opacifies and then the right-sided structures before going to the left side. And so after we CT'd this patient, they actually also had a persistent left-sided SVC, which is typically not associated with these type of defects. But again, with congenital heart disease, multiple defects can kind of happen at the same time. And so they had a persistent left SVC, an anomalous pulmonary artery, and a sinus venosus defect. And then when we injected from the right side as opposed to the left side, we saw that that we were directly targeting essentially that superior vena cava and where the sinus venosus defect was, so we could very clearly visualize the shunt. So you can see that you can see why we saw such profound bubbles on the transthoracic. Okay, 5 minutes to go, so I think I'll stop there.